Today, we're going to talk about a very important clinical condition in geriatric medicine. So, when you'll be working with these elderly patients, you would come across a lot of patients in a confusional state, disoriented in time and place, having difficulties with their short term memories as well as long term memorizations. And then also, they would be facing problems in performing even the simple tasks such as calculations or driving, household work. So, just having the background knowledge towards the different conditions that can arise in the neurology of such patients encompasses a very important clinical condition which is known as the Alzheimer's disease. Amongst the long list of conditions that can arise in these elderly individuals, for instance, we have the clinical condition of Parkinsonian syndrome, which can even have a similar presentation in these individuals, but upon investigations and upon very close history taking, specifically when you'll be taking the corroborative history from the relatives, that is going to highlight a lot of features. Specifically, the problems with the memory, they're going to start off earlier. But they remain unrecognized in these individuals. Sometimes they are considered to be a part of the aging process, and rather they're not considered as some organic process is causing such memory problems in these individuals. So again, just having the epidemiological factors that are surrounding this condition of Alzheimer's disease, we must know that approximately, it's just an approximation, and a lot of trials, a lot of researches have basically highlighted the occurrences of Alzheimer's disease in almost 10% of the individuals who reach the age of 70 years. They usually suffer from this kind of a condition which is known as Alzheimer's disease. Now, we as clinicians, we as physicians must be well versed with this condition. What are the causative factors? Again, what are the risk factors? Because having the patient education is very important over here. To make them know that these are the particular risk factors that can basically make you more prone to the development of this condition in your later stages of life is very important over here. It can be the side effects to some drugs, it can be the environmental conditions, such as the exposure to certain pathognomonic materials in the environment is again very important over here. Again, a lot of conditions, for instance, the systemic conditions of diabetes mellitus, hormone replacement therapies in females specifically, make you more prone, make you more at a risk of developing this condition of memory loss, which in layman terminology, you can just memorize it to be having difficulties with memorizations. So it can be an amnesia. Again, I would suggest specifically and scientifically, it can be an anterograde amnesia, or it can be a retrograde amnesia of the past. So this is all about this particular disease that we're going to study in detail today and discuss the different features that are encompassing this particular disease. So once you have these patients of Alzheimer's disease, you must know how to manage these cases in the particular manner. How do you go about in a step-by-step manner and manage these cases of Alzheimer's disease? Why is it important to study this disease? Is again one of the key concepts that you have to clear at this level. You must know that the quality of life is compromised when an individual is suffering from Alzheimer's disease. There are different stages of this disease. So he may be at a very early stage when he comes up to you, or even it can be the later stages of Alzheimer's disease. We must educate the patient as well as the caregivers who are out there to help out the patients, because sometimes there is a phenomena of a burnout in the caregivers, because it's very debilitating for the patient himself or herself as well as the people who are surrounding him. When he's suffering from that memory loss episodes, wandering around, not able to perform even simple tasks by himself. So he becomes basically dependent on the people who are providing him care, the family, of course, the friends, of course, who are out there. So the whole aim of the treatment and the whole management guideline is to provide support to the patient as well as to provide support to the caregivers as well as the family who's out there. For instance, you come across a patient who's suffering from memory loss, maybe, because in 20% of patients, they would present with a non-memory condition of Alzheimer's disease. They won't be suffering from any sort of memory loss, but there would be the other features of Alzheimer's disease. Maybe it is the rigidity, maybe it is the miscalculations. Then again, there is a very important phenomena which is resembling the psychotic conditions, that is the delusions, which are profoundly found in these patients of Alzheimer's disease. So if you have this mixed picture of Alzheimer's disease, and when you would start off with the investigation of these patients, you're going to carry out the CTs and the imaging techniques just to rule out the other phenomena. What is the differential diagnosis that you have to keep in your mind? It can be the visual disturbances when the cortical areas are involved due to some sort of a stroke syndrome, vascular phenomena, either it is an ischemic phenomena or either it is the hemorrhagic variety of stroke and it is affecting any particular areas of the brain. Again, we have a lot of neoplasms that sometimes present with this kind of a memory loss in the individuals. Even the speech is disturbed. There are the problems of dysarthria. Then we have dysphagia that are usually collaborated with the patients who are suffering from some sort of neoplasms. And even the memory is also affected in these conditions or in these tumorous conditions. Moving on, we have the other syndromic conditions. For example, we have the frontotemporal pontine disorder. It is again going to present with memory loss, and it is going to be featured when you are going to carry out the radiological examinations that is going to highlight whether it is some sort of a frontotemporal disorder or not. We have other disorders. For instance, we have the Creutzfeldt-Jakob syndrome, which is again presenting with the memory loss in these individuals. So when you carry out the EEGs, that is the electroencephalograms, or the positron emission techniques are applied, that is going to highlight the factor, and the normal studies are found in such condition. On the other hand, obviously, we can have infections, meningitis, and CSF studies are also, if they're carried out in patients of Alzheimer's disease, we found that the CSF is found to be in the normal condition. How do you differentiate a normal pressure hydrocephalus from Alzheimer's disease? It is usually the patients of normal pressure hydrocephalus, they present with a gait problem, an uncoordinated gait along with the memory loss. So this is the usual presentation of normal pressure hydrocephalus. I would again like to emphasize on the factor that it's very important that you go through all of these patients, normal pressure hydrocephalus, or either it is the Creutzfeldt-Jakob syndrome or it is the Parkinsonian disease. You must know what are the typical pictures of these patients. Experience basically makes you more perfect at diagnosing these different degenerative clinical conditions. For instance, a patient of Parkinson's disease would have a stooped posture. The speech is going to be affected. The pill rolling, the cogwheel rigidity is going to be present, and the patient is going to have a masked facies. That is very important in the Parkinsonian disorder. So these are the characteristic features that is going to highlight and that is going to differentiate the condition of Alzheimer's disease particularly from the other disorders which can even present to you with the memory loss. Again, chronic alcoholism is one of the syndrome out there. Vitamin deficiencies are going to be seen. When you carry out the baseline investigations, you're going to focus on the folic acid deficiencies as well as the vitamin deficiencies, because sometimes even these deficiencies present in the outpatient departments with the memory loss. So these are some of the differential conditions which even present to you with memory loss, and you as a clinician have the duty to differentiate the Alzheimer's disease. The mainstay of differential diagnosis and the definitive diagnosis is obviously when you carry out the CT scans. It is going to show the shrinkage in the cortical masses as seen over here. You can even have the comparative study over here that a healthy brain has to be basically differentiated from mild cortical degenerations, in which we usually observe atrophy to milder to moderate levels. And then we have the severe Alzheimer's disease, in which we observe the spatial cortical atrophy at this level in severe Alzheimer's disease. So as you can even appreciate over here that when we'll be, this is of course a diagrammatic representation, but when we'd be carrying out the CT scans or MRIs, that would basically appreciate the fact that we have a severe level of atrophy that is noted down at the cortical level. Now, the symptoms are again depending upon the particular level of the cortex that is affected. For instance, if it is the frontal lobe that is affected, that is going to affect the overall personality of the individuals. The thought process is going to be affected. It is going to be a much lowered and slowed down thought process in these individuals. For that sake, when you'd be carrying out the clinical examination in these individuals, that is going to highlight a lot of factors. For instance, the visual-spatial differentiation that is tested by giving out simple puzzles to the patient and asking him to solve them, or telling time, again, small calculations that are made by the individual, the puzzle solving, again, problem solving. These are the techniques by which you examine whether the patient is suffering from some sort of a thought-related process that is damaged in these individuals or not. Again, a lot of individuals suffer from aphasias, difficulty in speech, depending upon whether the Broca's area, that is the major motor area for the comprehension of the speech, that is affected in these individuals, if the specific temporal lobe is affected. Again, if it's the vernix area that is affected, there would be fluency in the speech, but the comprehension would be affected in such a case. If it's the occipital lobe that is affected in these individuals, then obviously there would be some visual disturbances that are noted down in such individuals. Apart from Alzheimer's disease, we have a lot of other syndromic conditions that even present with cortical atrophies. For example, we have the occipital lobe atrophy syndrome, in which there is this separated atrophy of the occipital lobe that is affected in these particular individual. These patients are not suffering from Alzheimer's disease, but for some idiopathic reasons, there is atrophy noted down at the occipital lobe, having the particular problems with the visual disturbances. Then we have the other syndromic conditions, for example, the logopenic aphasias. In such syndromic conditions, these patients of logopenic aphasias are suffering from cortical atrophies that are affecting just the Broca's and the vernix area. That is the area of speech are affected in these patients. But these are the isolated conditions in which not all the cortical areas involved, and that is why they are not termed as patients of Alzheimer's disease. They are separated, and they are, again, they have their own entity and they're diagnosed separately. So having the background knowledge of even such syndromic conditions is very important, and they would be basically a part of the differential diagnosis that you're going to make. As I was mentioning, we have the posterior cortical atrophy syndrome, we have the visual processing dysfunction syndrome, and then we have the kinetic rigid dystonic syndrome. All of these are basically some sort of disorders that are represented as atrophy on MRIs and CT scans, and they are resembling conditions with Alzheimer's disease, but they are the isolated conditions, and they should not be confused with this degenerative disease that we are studying today, which is known as Alzheimer's disease. So again, basically, one should be well versed with the clinical manifestations of Alzheimer's disease to have a correct diagnosis in these patients of Alzheimer's disease. As we have already gone through a number of conditions which can be put in the differential diagnosis, we should be well versed with this condition, Alzheimer's disease, and how we can identify the different stages of Alzheimer's disease. Either the patient is suffering from an early stage. An early diagnosis is very important in Alzheimer's disease because that would basically help you develop a rapport with the patient, and also to develop a rapport with the relatives and the caregivers who are out there and who are basically helping the patient. Why is it important? Developing a rapport when the patient is having the thought process and he's in the early stages of disease, and you basically make him educate towards his own disease and how to basically fight with the condition that is going to worsen with time. So this education is very important out there. Safety is very important. You make the patient know the fact that different places, even at his home, for instance, the staircase, washrooms, they have to be safeguarded because the patient might not be well versed with this condition, that there are some problems, there are some aphasias or uncoordinated movements that are associated with this condition of Alzheimer's disease even in the later stages. So to safeguard the patient even at his or her home is very important over here. Education is very important, and self-awareness towards this condition is very important over here. We'll go through the early stage first of all, and knowing that the patient must be suffering from some sort of memory loss. Either it is an anterograde memory, learning new things would be affected in such a case, and sometimes it can be a retrograde memory. Retrograde memory is basically encompassing the fact that he or she might not be recalling the different incidents of the past, the different important incidents of the past. So that is how it can be affected, and it can basically affect the quality of life of the individual. Sometimes the patient wanders off and he doesn't know how to get back to his or her own home. So wandering out, and again, it's very important that he might be suffering from an early phase but might move on to an advanced stage of this particular illness out there. Then a lot of patients suffer from seizures. These seizures, again, are resembling the epileptic seizures. The patient might be suffering from the tonic myoclonic seizures. The jerky movements are there. They are caused due to the rigidity that is going to develop even through the advanced stages of this particular disease. So the safety measurements, again, as we were talking about, the staircases, washrooms, even the patient is not allowed to drive with the passage of time. So these are the precautionary measures that you have to take even when you diagnose a patient and he or she is in the early stages of this particular illness. You have to safeguard the patient. Moving on, we have the cognitive problems. You're going to check out for these cognitive problems by asking the patient to solve simple problems. Again, calculations, small calculations are put forth, puzzle solving or problem solving techniques are used to note down whether the patient can go through these problem solving techniques or not. And that is going to highlight that the patient's thought process is affected. Whenever there is some damage to the thought process, there are going to be some sort of hallucinations and delusions that are the fixed thoughts that are present in these individuals. So you need to look for them. When you're taking the history in detail from the patient, write down any sort of abnormalities that are noted down in the thought process, and you have to document them accordingly. Changes in the environment. So whenever, as I was already mentioning, there is a phenomena of a caregiver burnout. So usually the patients, caregivers, they need help, and there are a lot of societies out there that are helping the patients with Alzheimer's disease. So whenever there is a change in environment and the patient is put forth to such an association and he's moved from his home to that caregiving support program, there is a change in the environment that is sometimes miscomprehended by the patient. And the patient then develops different sorts of delusions and hallucinations along with that. One of the trick of trait over here is that you can write down or jot down some of the names, and again you ask the patient to go through those names of the areas as well in that society, so that he can get more comprehended towards the environment that he has been moved into. Make him or her more comfortable to the new environment as he goes into that society for caregiving processes. Then social graces, they're usually present in the early stages of life. So even if there are the phases of memory loss, the patient usually retains these social graces even till the end stages. So it's quite surprising, but they are present and they're retained. And usually the patient the patient's social gracing would not be affected in the early as well as even in the later stages of the disease. The diagnosis of the early stage of Alzheimer's disease, as I was mentioning, it is very important because the prognosis is again out there and we have a lot of research factors. The life expectancy is usually 8 to 10 years after the initial diagnosis if he or she is in the early stage of this particular disease. But in a lot of cases, it is sometimes almost delayed up to 25 years if a proper support system is there and proper techniques are being used, then we have the life expectancy improved to almost 25 years. So this is something that we have to focus on, and then obviously the quality of life has also to be maintained for these individuals. Moving on, we have the middle stage of this condition. So obviously it is an ongoing process. It is a degenerative condition that is going to affect the cortical areas more and more with the passage of time. It is not going to stop even after treatment, and even after giving all of the required treatment, the people usually progress to the milder stages after the early stages. So what is causing this degenerative process to go on? It's basically some sort of genetic conditions that are present, genetic mutations that are present. So again, even if we provide the treatment, the genetic mutations won't stop. And that is why it is an ongoing process and it is going to advance on to a next level. With the passage of time, the patient will become more dependent and he won't be able to work independently. So usually he would find problems even at his job. Usually the females who are working at home or housewives, they would find difficulties in even the normal household chores. So this would be some sort of a problem that would accompany such individuals, and sometimes even a lot of patients, they remain undiagnosed at an earlier stage. So sometimes, and most of the times, you would come across patients coming up to you in the middle stage of the disease because they would be having problems professionally, and that would basically help them go to a doctor or see a doctor to help them diagnose what is the problem with the cognitive ability or with the thought process. And when you'd be carrying out the radiological investigations, that is going to highlight the factor or the underlying process of Alzheimer's degenerative processes that are taking place for such individuals. Sometimes these patients would get lost, they would wander off, and they wouldn't find their way back home. So, this is one of the conditions. They would be found wandering around in the streets, and sometimes they would be lost, not even oriented in time and place and in person. So, a lot of people would report to you in such lost states, and when the further investigations are going to reveal the fact that this patient is suffering from Alzheimer's disease. Confusion is another very important trait for this condition. Then we have basically they become more and more dependent with the passage of time, and that is why they would be needing a constant nursing support around them. And that is basically a daily supervision would be required for even the normal day-to-day chores that they would be performing, personal things, for example, going to the washroom and changing clothes. All of these would even require help with the passage of time. Language may be impaired. So, as I was again mentioning the fact that if the temporal areas are affected, the Broca's and the Wernicke's, that is going to affect the fluency in the speech, and that is basically going to be seen in the language of such individuals. Visual spatial defects is going to make a lot of tasks difficult. For example, even eating properly, that would be affected, and that is why they would be suffering from self-neglect if a proper caregiving support is not provided. Infections and a lot of traits are going to be seen along with that. So this is again one of the complications that is going to arise with the passage of time. Reading time is going to be squeezed on, and the concentration levels are basically not maintained to a very high level. So that is going to affect even the reading time of the individual. These are all the traits that are helping the clinician diagnose that the patient is going in a more advanced stage of the disease. So these are some of the clinical conditions out there. Then moving on, the patient reaches the later stages of this condition, in which he or she may wander off aimlessly even at night. So it's again very important that that a caregiving support is provided. And again, as I was mentioning, there is a burnout of the caregivers, and sometimes in the later stages they have to be sent to these specific agencies and societies who are working for these patients of Alzheimer's disease. Loss of judgment is also seen, and loss of reasoning. Then delusions, the delusions of prosecution, delusions of infidelity, theft. These are very important delusions that the patient might be suffering from. They're obviously seen in the later stages of this particular disease. Again, this is a delusion of paranoia, which is known as the Capgras syndrome. It's again one of the conditions that is seen in the later stages of Alzheimer's disease. So it's basically worsening the whole scenario. And it is again focusing on the fact that proper agencies and welfare societies are out there to help out these patients and have a better management plan made up for these particular patients of Alzheimer's disease. Disinhibition, rage, anger. Why is that so? Because the patient is basically stopped from working, stopped from driving. He's becoming dependent day by day. So that is basically going to make the anger more enhanced with the passage of time. And then there are these rages and disinhibitions that are significantly seen with the passage of time. Then we have the other clinical manifestations such as passivity and withdrawal that is seen. Patients would have disrupted sleep-wake patterns. So again, the insomnia is also going to be marked in these patients. Sleep patterns are disturbed, and symptomatically we treat the patients for the problems accordingly. Nighttime wandering is seen, muscle rigidity. Again, it is going to be confused with the Parkinsonian disease, in which we have the cogwheel rigidity. And over here, we have sustained tone of the muscles. So this is again differential over here. How are you going to see the differences between a Parkinson's patient and an Alzheimer's disease? Later in this particular disease, patient also develops Parkinson's disease. So it's usually a mixed picture. And you have to basically identify whether the patient is suffering from Parkinsonian symptoms or not. Movements are going to be slowed down, and there is an overlapping with the Parkinson's disease. So this is the complete late stage developments that are seen in patients of Alzheimer's disease over here. The end stage, the patient would have masked rigidity over here. He would become mute, bedridden, and completely dependent on the nursing staff. They would even require help for dressing, eating, and toileting. There would be brief contractions of the muscles noted down at small joints of the wrist and the ankle that are significantly present out there. The diagnosis would require the medical imaging techniques. As we had already mentioned, the final diagnosis would rely on the CT scanning. Then we have the MRI scans being done. The positron emission techniques this is one of the techniques, and then EEG scans, that is the electroencephalograms. These are very important over here, and these studies would relate to the fact whether there is some sort of cortical atrophy seen in these patients or not. CT scans would reveal obviously the cortical atrophy. MRIs are going to further comment upon it, and positron emission techniques are going to further highlight the particular areas that are affected for such techniques. A normal EEG scan is usually shown in these individuals. A lot of individuals would be suffering from seizures. There would be some abnormalities that would be noted down during that seizure activity. So it is going to be noted down when you carry out these EEG scanning techniques. The risk factors for the development are the old age is one of the important risk factor. Almost 10% of the patients who reach the age of 70 years develop Alzheimer's disease. Then, as I was already mentioning, it is basically a genetic mutation. So the family history is very important over here. Females are usually more predisposed to the development of this condition. Genetic mutations specifically at chromosome number 21, chromosome 1 and chromosome 14 are very important. We have the APP gene, that is the most important gene located on chromosome 21, and any mutations can affect the amyloid deposition and further, obviously, the development of Alzheimer's disease. Head trauma, a lot of patients with a recent history of head trauma usually present with this kind of a condition. And then obviously we have the low education attainment that basically lowers down the IQ level and further make the patient more prone to the development of this condition. Then we have an exposure to aluminum and mercury. As I was mentioning, the environmental conditions are even very important. So a lot of patients who were exposed to aluminum and mercury were at a risk of developing this condition of Alzheimer's disease. Viral infections and diabetes even make you more prone. Low intake of fruits and vegetables basically result in the vitamin deficiencies, lowers the IQ levels, affects the memory, and makes the patient more prone to the development of Alzheimer's disease. So these are some of the risk factors in the environment and in the person as an individual, which are making the person prone. The underlying pathological features or the cascade of events basically depend upon a lot of factors. There are a lot of cascade of events. There are different ways in which a patient can result in this kind of a condition. We have an amyloid hypothesis in which the amyloid deposition is responsible. We have the vascular hypothesis, the glutamatergic hypothesis, and we have the cholinergic hypothesis. So first of all, going through the amyloid way, we move on that basically the hypothesis is that an abnormal amyloid protein precursor cleavage is present, which results in the accumulation of insoluble beta amyloid in the extracellular space. It forms plaques, and that basically results in neurodegeneration. So the amyloid deposition is one of the underlying process which can result in the neurodegeneration, and it is even present at the histopathology when it is studied in detail, and obviously it is going to result in Alzheimer's disease. Again, a lot of hypotheses were related to the aging process and the vascular risk factors that result in brain hypoperfusion, affecting the neuroglial energy crisis, and there would be mild cognitive impairments. Thought processes would be affected, resulting in neurodegeneration, and there would be a final picture of Alzheimer's disease, even concerned to this process. The glutamatergic hypothesis suggests that N-methyl D-aspartate receptors have low levels of activation, which results in the low levels of neurotransmission accordingly, resulting in the chronic calcium influx in neuron, interfering with the signal transduction. So that would basically result in the hypophosphorylation of tau proteins. Neurofibrillary tangles would be formed. So even when we look at the histological picture, we come across these fibrillary tangles out there that are a very important feature of Alzheimer's disease. So again, it is a feature of neurodegeneration and resulting in the thought processing effects seen in the Alzheimer's disease. The cholinergic hypothesis suggests that the loss of neurological neurons result in the loss of acetylcholine, and that is resulting in Alzheimer's disease. So these are the different hypotheses. Mainly, it's basically a mixed picture, and all of these may contribute to the development of this condition, which is affecting the memory of the individual, known as Alzheimer's disease. This is the histological picture out there. As you can see, these are the neuritic plaques. These are the complex neuritic plaques that are formed here. The neurofibrillary structure that is seen out there is one of the important features of Alzheimer's disease. So all of these pathological pathways basically contribute towards these factors. The genetic considerations would be at preselin 2. This is one of the genetic mutation at chromosome 1, which is thought to be responsible for the development of this condition. Then we have the preselin 1 on chromosome 14, which is again one of the hypothetical genetic mutation. Then we have the apogene on chromosome 19, which is again one of the key factors, the APP gene on chromosome 22. All of these genetic mutations play a very important role in the development of this particular condition. Again, finally, we have the clusterin phosphatidylinositol binding clathrin assembly protein. It's again one of the genetic mutations. So these are the genetic considerations that we have to keep in mind. The treatment basically consists and starts off from the patient management. So it's again very important to highlight the fact that having the caregivers educated regarding this kind of the particular condition is very important over here, because with the passage of time, it's a slowly progressing disease, and the patient is going to go on to the later stages of this particular disease and need the social support out there. So this management is again very important over here. We have to make the patient go through the notebooks. So it's again very important to write down or jot down the certain very important things that he has to keep in mind. Developing a rapport with the patient over here is very important, and the major aim would be to maintain the quality of life and maintain the safety of the individuals for this particular instance. Driving is usually inhibited in these individuals, and that is basically going to increase the anger and agitation. So these are some of the points that you have to keep in mind when you're managing these patients. Daily reminders are put on by notes and different stick-ons that you can place nearby the patient. the family members and developing a rapport with these family members, educating them regarding the disease, and letting them know that a lot of support agencies are out there. So they, whenever they need help, they can go out and ask for help, and they may render the nursing staff for the care of the individual. So this is very important. Then communication is very important. The catharsis is very important with these patients. Then we have the adult daycare centers that are present, and they are working out there day and night. A lot of nursing staffs are available to provide care for these individuals out there. So this is a very important part of the patient management out there that you have to keep in mind. Then obviously we must move on to the drug therapy that is present. So again, we have to even provide the supportive treatment, the symptomatic treatment to the patient, depending upon the type of symptoms that the patient is having. Again, the drug of choice over here, the medicinal drugs being used are donepezil, that is almost 10 milligrams. We have the rivastigmine, that is almost 6 to 9.5 milligrams. This is the dosages per 24 hours. Then we have the galantamine, 24 milligrams. And we have the memantine, that is almost 10 milligrams. The side effects with memantine were the hepatotoxicity that was noted down for these individuals. And even if we give the cholinergic drugs, it was basically related to a lot of side effects, having nausea, abdominal pain, and they were quite adverse. So they were inhibited. And right now, the drug of choice is donepezil in a dose of 10 milligrams per 24 hours. So this is the drug of choice up till now over here. So over here in this particular lecture, we just focused on a very important geriatric condition that is affecting the memory of the individuals. Later on, the patient becomes dependent on the surroundings, on the nursing staff. So it's again very important to diagnose at a very early stage and have the safety of the individual as well as the people who are surrounding and the family members. So the management is very important, and the correct diagnosis is the mainstay of this particular disease. So that is the end to this lecture. Thank you for watching sqadia.com.